there's still a lot of mystery around the health and happiness and general, just, equity of being a woman. So we formatted it as a webinar so that you don't have to show your face if you don't want to, and you can ask anonymous questions. Another thing to note, if you asked a question in advance of, thank you, Kelly. If you asked a question in advance of this panel, we have actually formed our questions for the panelists based on your questions. We're going to try to answer as many as possible. There were so many. Thank you, thank you, thank you. That was immensely helpful. So as we get started, go ahead and check in the chat. Tell us where you are. You don't have to tell us who you are if you don't want to. And just let us know, what is one area of women's health that is most mysterious to you? And then we'll kick off the panel. One area of women's health that is most mysterious to you. I'll answer it for myself, and then I'll ask each one of the panelists before we kick it off. For me, it's menopause. I feel like that's one thing I've never really chatted with anyone. Kaylee agrees. Never really chatted with anyone about, other than my mom or my grandma, who mentioned hot flashes like in passing. What about you, Cynthia?
Oh, that is a great question. Okay, mine is kind of personally relevant, and I'm sure a lot of other people here will agree, but autoimmune disease. So mysterious, so confusing. The role of gluten. I got a lot of questions.
Ooh, so many things. Dr. Yen, the area of women, I mean, like, you know a lot about women's health, but what's an area that's mysterious to you still?
I am not the menopause expert, but Pandia Health is going to be going into menopause, and we have a menopause expert. So I still think there's so much we don't know because they haven't done the research, and there's not that much, there's not many options. Like the birth control pill, we have 40 different options. There's only one combined treatment for menopause, and it's crazy expensive because it's on patent. So I hope that we will develop more options for us.
Yeah, we got a whole pill for erectile dysfunction. Come on, whole slew of pills. Jamie, what about you? What's the area of women's health that's still mysterious to you?
Like vaginal infections and yeast infections, BV, the differences, how to tell what's going on. That's very still confusing to me.
Yeah, what's going on there? Dr. Jeelani, can you tell us what is an area of women's health that is still mysterious to you? You know a lot too.
Yeah. Well, why not all embryos implant and become a baby drives me crazy. It's really specific, but
very specific. And I think that there are a lot of people who wonder that as well. I'll just briefly go over what's going on in the chat. Hannah says it's wild that we literally can grow a human. I agree. Caroline from Madison, learning about my body off birth control. That is also crazy to me. I haven't been off birth control candidly in probably like 19 years. Breastfeeding, Jenna, thank you. Hair loss for women. Ashley from Chicago, fertility and freezing eggs. There were a lot of questions about freezing eggs and fertility. And Melissa recently got off birth control. Periods changed. So let's jump in because we have a lot to cover. I'm going to let all of you introduce yourself, but I'll popcorn you so you don't have to guess. Cynthia, you go first. Tell us who you are and what you're working on at Styx.
Yeah. Hey, everybody. So nice to meet you. My name is Cynthia, and I am one of the co-founders of Styx, along with my always better half, Jamie, who's probably below next to me, above me on the screen. Hello. Thanks. And at Styx, we are the no judgment health brand that provides women the products, education, and community that they need to confidently manage their health. We started with pregnancy and ovulation tests. We then launched into the UTI category, and just was a week ago, we launched a prenatal vitamin. And yes, very exciting. Oh gosh. All of it is augmented with tons of digital education and community resources. So excited to be here.
Awesome. Thank you, Cynthia. We'll go right over to Jamie. Jamie, what's going on?
Hey everyone, I'm Jamie. I'm Cynthia's co-founder working on all things Styx. I won't repeat exactly what she just said, but we'll be answering all your questions about pregnancy testing, ovulation testing, UTI testing, and all things Styx.
All right, Dr. Yen, you're up.
Hey, I'm Dr. Sophia Yen. My mom said, always claim all your titles. So claim all your titles, ladies. And I am CEO and co-founder of Pandia Health. We are the only women-founded and women-led and doctor-led company in birth control delivery. And we're building the online health brand that women trust. We're starting with birth control, but we're soon to launch acne and menopause in the near future.
Love it. And Dr. Jeelani, I do not know what the second set of letters after your name means, so that's exciting, but tell us about you and bios.
I am Dr. Roohi Jeelani. I'm a reproductive endocrinologist and infertility specialist. In order to become that mouthful of type of a doctor, you have to be double board certified. So that FACOG stands for Fellow of American College of OBGYN. So you do 4 years of your OBGYN residency and training and get board certified. And then you go on to do another subspecialty for 3 years in reproductive endocrinology and infertility. And so a lot of training to help women achieve and build their ideal family size. And I'm at Vios in Chicago, but we're all across the Midwest.
Awesome, thank you. And we've sort of phased tonight to go kind of in order of the lifespan of a woman, but know that not all women are the same and not all women's wants, desires, needs, or bodies are the same. We acknowledge that. And we also acknowledge that some of these topics might be triggering for some of you. Some of you may be having trouble conceiving, and we just want you to know that there is someone out there who can be there for you too. So if anything does that for you tonight, let us know and we can connect you to the right resources. But we want to acknowledge that going into this. We're going to start with testing and fertility. We'll call it testing and pregnancy. So Cynthia, let's start with you specifically. So you shared that the company was born out of sort of a run-in with a boyfriend's mom when buying a pregnancy test. Can you share how that story shaped the company Stix?
Yeah. So it was awful. If you're laughing on the other end of this webinar, that makes sense. Pretty much everybody does when I tell this story. But yeah, like you said, I ran into my boyfriend's mom buying a pregnancy test. I was hoping to not be pregnant, which is also a really common use case for these products, which isn't often talked about. And I ended up running out of the store and I called Jamie in tears. And Jamie and I had worked together for many years and we knew we wanted to start a company, and we just took this moment from, oh crud, this is terrible, to, oh my God, this is this huge opportunity.
I love that. And out of that, Stix was born, and you explained some of the testing that you're doing now. But I'd love to ask both of you, Jamie and Cynthia, Stix offers a full suite of testing, ovulation, pregnancy, and UTI. Can you talk about like the why of the company and what's next after that kind of suite?
Yeah, so we decided to start with diagnostic testing because we really firmly believe that the more you know about your body, the better decisions you can make. And there are all these products out on the market, but you don't really know what you need and when you need it. So our philosophy is to kind of, provide women with a test that they can better understand their bodies with, and then go on to help them either treat, manage pain, or just learn more.
Awesome. And you'll notice, attendees, that I'm moving at a fast clip because of the amount of questions you ask. I want to make sure that we get to your specific questions too. So if at any moment you hear something that triggers another question for you, just add it to the chat or the Q&A and we'll try to get to that too. But third question for Jamie and Cynthia, UTIs have plagued some of us more than others. If I say this without blushing, it'll be a miracle, but I'm still going to give you a personal story here. But I was getting them like for years, every single week, because of the kind of condoms we were using. Nailed it. What other causes are there, and how can you prevent them? And do you need to go to a doctor if you think you have a UTI?
So there's three. First of all, UTIs can happen for all sorts of different reasons, and that's really important to know. And I would wager to bet that most of us here have had at least one UTI in our lives. 60% of women have, and up to a quarter of women actually experience what you were just talking about, which is recurrent UTIs. There's three big moments that can often correlate with UTIs. And one is having frequent sex. The other is during pregnancy, in which the baby puts pressure on the bladder. And then the third is during menopause. Sorry.
I said fascinating.
It is fascinating. And then Jamie, you want to tell us about how to help prevent UTIs?
Yeah. Yeah, there are also some other things that can cause them, like if you hold in from going to pee for too long, or you're not drinking enough water, or really like Cynthia said, there are so many reasons that you could get one. It's not necessarily tied to, just having sex, which is why there's such a stigma around them. But what we do at Sticks is provide a UTI test that you can take at home. So, that moment if you've had a UTI where you're like, oh, something's going on, and you just chug water and hope it goes away and try to wish it away. We don't want that to ever happen again. So at home UTI test, then you can know that, like, if you need to contact your primary care provider and what to do. And until you do contact your primary care provider, we have a couple products to help. So we provide pain relief. If you've ever taken like azo, that pill that turns your urine orange, it totally numbs the pain. And then we also have a preventative supplement that you can start taking on a daily basis with ingredients like D-mannose, cranberry extract, vitamin C, turmeric, to really prevent UTIs from happening.
That's great info. To the doctors, anything you want to tack on about UTIs and any impact that they may have on your health if left untreated? You can also say no.
In pregnancy, they can get very dangerous if it's left untreated. It can actually ascend into the kidneys, and you may need a preventative treatment for a UTI once you get a UTI or a kidney infection in pregnancy. So every time you go, when you're pregnant and your doctor checks your urine, I'm so sorry, that's what they're checking for, to make sure that there's no protein, no ketones, or any signs of any infections. And another thing, we said menopause earlier, Cynthia and Jamie had mentioned that. And one of the big reasons is hormones that we don't talk about, that when you're menopausal, there's a hormonal deficit, which may lead you to increased risk of UTI. So if we address the hormonal component, like Dr. Jeana had said, then you can prevent that.
And just, coming from academia, many physicians would like to get a culture of your urinary tract infection rather than just starting antibiotics, because there's the risk of antibiotic resistance. So just something to know and to think about. And there's definitely a different treatment of recurrent urinary tract infections versus like the first time urinary tract infection.
Oh, I want to ask every question. The only thing we haven't talked about, Cynthia and Jamie, is ovulation testing. Is there anything you want to add about that, or how sort of you see your members using it?
Yeah, well, an interesting thing about ovulation testing is when we launched the ovulation test, we actually heard, I think, like 90% of our customers didn't even know you could test for ovulation before they found Sticks, and they saw some of our articles about it. So that was really interesting. It just shows that there's a lot of education to be given about ovulation, and whether you're trying to conceive or not, just getting in touch with your body and what's happening at different times of the month can be really powerful.
Awesome. All right, let's talk about periods and birth control. Quick clip. Dr. Yen, Pandia seeks to make birth control really accessible through virtual provider appointments. In my experience, every appointment comes along with PAP. Do we need an annual PAP anymore? How do you kind of get away with not doing it?
Yeah, so I've been giving a talk to a bunch of college students and sororities, and the latest guidance, it used to be as soon as you started having sex, you needed a pap smear. Then it was 2 years after you had sex, because most of us would clear it, and you don't want a false positive and work up and all this stuff if it's just going to go away. However, we've now moved that to 21 years old. And so for 3/4 of the college population, not applicable. And so to educate people, you do not need a pap smear until you're 21, unless you're immunosuppressed. So if you have HIV, or if you're on chronic oral steroids, and maybe because if you get it, then your body won't get rid of it. But most people will do fine at 21. And actually in Europe, they don't do it until 25. So the United States is just being hypersensitive, hyper careful, and doing it at 21. And now the cool thing is now they're doing it every 3 years if it's normal. If it's abnormal, then they got to do it more frequently, but it's every 3 years. And then once you're 30, they're doing it with HPV testing. And then if they check the HPV and it's not a high risk HPV, or it doesn't have any HPV, or it's only the low risk, then they can do it even less frequently. So don't need a pap smear, don't need sexually transmitted infection testing, don't need a pelvic exam. before starting contraception. I try to educate my medical students and physicians that I teach. Don't withhold birth control because you want to get a pap smear, because you want to get sexually transmitted infection testing. And you should get that done at the appropriate ages. And for anybody 26 and under who are heterosexually or homosexually active, should get a sexually transmitted infection test, chlamydia once a year, or gonorrhea, and gonorrhea if you want, and HIV once a year. But you don't have to. You can separate those two events. They don't have to happen at the exact same time.
Awesome. And we got a lot of questions around like the safety of birth control, especially when taken for a long time, and its effects on fertility later. So this may be a tag team between Dr. Yen and Dr. Jeelani, but let's start with you, Dr. Yen. Talk to us about birth control. How long can you take it safely?
Yeah, so the pill, all the forms of birth control you can use all the way into menopause, because the whole point is to prevent unplanned pregnancy. And I'm even advocating that we use birth control not for birth control, but for hormonal control, and to only bleed anybody with a uterus that's bleeding 1 week out of 4. I want you to know we can hashtag make your periods optional, and you can have it every 3 months, every 6 months, or never, as long as you're on these methods. But the question you're asking is, does birth control make you infertile? And the answer is that with the pill, patch, ring, implant, shot, and IUD, all of those, you will recover your fertility within 3 days. All the hormones are out of your body, but it will take you 2 weeks to regrow that lining, and then bam, you can get pregnant. What it is that they find that 10% of people, when they come off birth control, have a hard time getting pregnant. And it's not because of the birth control. If we took 100 people and then checked them 20 years later and they didn't go on birth control, 10% of them would have a hard time getting pregnant. And so 10% of people coming off birth control, we expect to also have a hard time. And what it is polycystic ovarian syndrome. 1 in 10 women will get or already has polycystic ovarian syndrome. And those women aren't popping out eggs. And so if you aren't popping out eggs, you can't get pregnant. And so people are confusing polycystic ovarian syndrome and blaming birth control as the source of their infertility.
Anything to add, Dr. Jeelani?
Yeah, birth control is great, but it masks your cycle. Not like masks it, but it mimics your cycle. So it gives you the estrogen and progesterone you need. So I see a ton of people that say, oh, I get regular cycles, but getting a regular cycle on birth control does not mean you innately get regular cycles. So it could be a variation. Like I've seen patients who got off of birth control and come in ovarian failure and say, oh my God, birth control did this to me. But no, birth control did not do this to you. It's something that you had, or something that was undergoing naturally. Birth control masked it. Same thing with PCOS. It doesn't make your cycles normal. And then that way, if you get off of it, you should get your cycles again and get pregnant. Birth control mimics your hormone. It's a hormone replacement, essentially. The only thing I say different is if you have an implant, like an IUD that goes in your uterine lining, you don't get resumption of your cycles immediately. It takes about 3 months to recover, to build up and actually lead into implantation. So typically, if you have an implanted device like a Mirena IUD or a copper IUD and you're looking to get pregnant, I say pull it and allow your body 3 months. So that 3-month rule where we hear, oh, I was told to get off of birth control to let my cycle regulate for 3 months, doesn't extend to all forms of birth control, but it does extend to those implantable ones that need to actually leave your system. Depo-Provera also is another form. It doesn't leave your system right away. So if you took the shot last month and you decide all of a sudden now you want to get pregnant, you have to wait till that leaves your system at that 3-month interval. So that's where that 3-month comes from. It doesn't apply to everything. Short birth control pills, patches, or rings, the ones that you can actually remove immediately are the ones that immediately go away. Implantable devices typically need a little bit to recover, where that 3-month rule plays.
Awesome. And that could be for Cynthia and Jamie, that could be a use case for the ovulation test too, if you're trying to figure out how your cycle goes back to normal as well. Anything to add to that?
I was just going to say that, obviously cycles are complicated and ever changing, and that sort of cycle tracking can be really, really helpful whenever you go through any sort of life change.
Awesome. All right. We had a lot of questions too about not trying to conceive. We'll call that NTTC. There were so many questions also about folks on the fence about having children as well, which I can totally understand those. I'm going to read a specific one to you, Dr. Yen. So if I know I'm not going to have children, what's the best way to be sure I won't get pregnant that doesn't involve birth control and won't totally mess with my hormones? She asked specifically about tubal ligation doesn't seem to be as effective as an IUD.
So yeah, I think maybe when she says it doesn't involve birth control, she means probably the birth control pill, patch, or ring, because it seems like she might be into the IUD. And that is what blows my mind. The implant is the most effective form of birth control under vasectomy. So I absolutely recommend vasectomy because tubal ligation is far more invasive. Like vasectomy is just outside, you make a little slit, and done. But for a woman, we got to go through the abdomen, find it, and do the same thing. So if you are in a heterosexual relationship, definitely get the dude to do it, the one with the penis or the testicles specifically, rather than the one with the uterus. But then second most effective is the implant, and then the IUD with hormone beat tubal ligation, which blows my mind because tubal ligation, snip, sip with like an inch in between and burn and tie. How does the IUD and implant beat that? But it also shows how crazy fertile your body is, that even with snip, snip, and burn and tie, you could still get pregnant, though it's like 5 out of 1,000 or very, very low, the incidence of that happening. But I'm the only doctor CEO of a birth control company. We will always tell you what's best for your health, even if we can't profit off of it. So the implant, the IUD with hormone, then tubal ligation, then copper IUD. And I know I saw a question later, the copper IUD, more blood, more cramps. So if you're a woman who doesn't notice any of your periods and you have very light bleeding, copper IUD. But if you're a person bleeds like stink, no, not copper IUD. If you're a person who feels every cramp that goes through your body, not copper IUD. But of course you can do whatever you want with your body, but I'm just saying that would be the side effects.
That's helpful. And we had a follow-up actually, I think, to the last question from Kristen. She was wondering if the bounce back time from coming off of the pill or taking out your IUD or implant, does it matter how long you've been on it to bounce back?
I think for Depo, for sure, the more shots you've had of Depo, the greater the risk of a longer period of it washing out of your body, because it actually lives in your fat. And so then it takes a while for it to come out. And so some people say it'll take up to 8 or 9 months off of Depo to rinse it out of your body. With the pill, the patch, the ring, theoretically, the medicine is out of your mouth, out of your body in 3 days. And that's why if you forget to take your pill, patch, ring for 3 days in a row, you get your bleed. But certainly if you're doing it the way I'm doing it, where I never bleed and I'm just like this, maybe when I come off, it might take me, a month or 2 for my body to be like, oh, I'm supposed to kick in, every 28 days or something like that. I don't know. Dr. Jeelani, what has been your experience?
I would agree. Depends on the duration of what type. If it's a short acting, like a low dose birth control pill, you'll get your period right away and it won't matter. That's one of the common myths that I see is, oh, I got off of birth control. I was told that I need to wait to regulate. And that's why I didn't come see a fertility doctor. Actually, not true. You're the most fertile the month after you get off of birth control, because your body's in a complete shock state. It was like, oh my God, where's my positive feedback? Where's all my hormones? So your brain goes in panic mode and secretes hormones at a much higher level. So your fertility is the highest month after. Once again, there's so many different forms of birth control. So it depends what you're talking about, but the duration of your birth control, how long you've been on it, does not impact how long you need to wait.
That's a really great segue into fertility. Let's chat about that. A lot of questions for you, Dr. Jeelani. The first one, I'd love to ask a personal question. You've been really open about your own journey of trying to conceive. Can you share what that's been and how that helps you relate to your patients?
Yeah, this is not my first rodeo, unfortunately or fortunately. I had treatment with my son. I was much younger. Social media wasn't as big back then. I don't even think it existed. It was those Reddit blogs. I'm probably dating myself, where you'd have to like go back to the conversation and see what they're actually talking about. But at that time, I really didn't share with anybody. I was in residency in a very, very big and very stressful program. So it was something that I kind of kept to myself. So I had my son and my daughter, took a little bit of time off because fertility is draining. So you finally think, okay, this is it. Like I said, I remember saying, God, please give me one. You got your one. And I was like, okay, I'm getting greedy. Give me two. So I was like, okay, we're good. We have a boy, we're a girl. But I always envisioned having 3 kids. So then I started my journey again. And as I got older, realizing that the egg quantity and the quality started to decline, I started with fertility preserving. I wasn't quite in a space. I was in a new job in a new state, a lot of news around me, and my kids were much younger. So we froze my embryos and said, we'll do it when it's right for us. And I think that's important to know, that truly there's no ideal time, but it has to be right for you. So then I started the transfer process a little bit later than I would have hoped, but now we're in the 2-week wait. I just did my embryo transfer last week. Hopefully it sticks. But yeah, I'm sharing because I wish there was something like this when I was going through it.
Thank you for sharing that. I know that there are tons of folks on this webinar who can relate. Lots of fingers crossed. I'm physically crossing my fingers, and Caroline's crossing her fingers virtually for you too.
Thank you.
Speaking of age and fertility, you mentioned age. There were a lot of questions specifically related to age and fertility. What are the truths and the myths about age and trying to conceive? One attendee asked specifically, I'd love to understand more on the time it takes to get pregnant and when to seek help at different ages.
It's a great question. So the reason why age and fertility matters, because as females, we're born with all of our eggs. So at birth, we have about 3 million. Then we hit puberty, and that number automatically dwindles down to about 200,000 ballpark, which is still a ton of eggs, but a huge decline. You see that delta, it's massive. Then every month, not that you're trying to get pregnant at 12, but our body's like, okay, let's go. Let's kick into biology. And it starts recruiting about 100 eggs every month. It only makes enough food or hormone to ovulate one, and then you lose all of them. So believe it or not, peak fertility is at age 23. So as a doctor, when I'm looking at donors, that's what I'm looking for. I'm looking for my mid to early 20-year-olds, because that is when they have your most optimal eggs. After 23, it starts to decline, but not a fast decline, just a steady decline. Then you'll see that decline kind of hit a nadir at 28. Then between 28 to 32, it starts taking another slow decline. Then at 32 to 35, takes another decline. What happens at 35, it's not a magic number where you lose all your eggs or you become infertile. It's that the time that your eggs have been in your body is so long that the risk of abnormality, meaning Down syndrome and trisomy, chromosomal abnormality, starts to go up significantly. So to give you a number, the risk of Down syndrome at age 34 is 1 in 1,000 about. After age 35, it goes to 1 in 200. Okay. So that's just one syndrome that's compatible with life. There's many others like that. So that's why you see the risk of miscarriage at 35 go up significantly. So what truly happens at 35 is that it becomes harder to get pregnant. So going back to your second question, when do you seek help? So if you're 35 and above, we know time is not in our favor. Then after 6 months of unprotected intercourse, doesn't matter if you're doing ovulation predictor kits, doesn't matter, if you are checking your cervical mucus, unprotected intercourse, blanket statement. If you've had unprotected intercourse for 6 months, then it's time for you to see a doctor. If you're under the age of 35, if you've had unprotected intercourse for a year, once again, unprotected, no matter whether you're testing or not, if you're not pregnant, you should see a doctor.
So the big age where we go from a cliff of a year to 6 months is 35.
35.
That's my age.
That's a good age. It's a new 20s.
35 is the new 20s. And it's interesting, you mentioned embryo freezing, egg freezing. There were a lot of questions about embryo freezing in general, whether it's effective or whether it's just sort of a money pit. Can you talk us through efficacy, which one is better, et cetera?
Yes, 100%. Can I address, somebody said, what if you can't get help? Like, what if you can't afford help?
Yes, please do.
Yes. So access to care is huge. I have a huge paper I just published on advocacy. So a lot of doctors are advocating for their patients, going to Congress, going to the Capitol and saying access to care is important. That being said, there's about 11 states that have mandated fertility coverage. So if you have the ability to move to Illinois. It covers 4 IVF cycles per calendar year. It covers egg freezing. It covers all your months. That's one. Okay. Or these bigger companies like Amazon, Facebook, Google, McDonald's, LinkedIn, Groupon, Starbucks, all of them have fertility, Nike, all of them have fertility coverage because they want women in the workforce. So they're encouraging fertility preservation. They have an allocated set of monies that say, here you go. We want you to build your family, but we also want you to be happy and advance in your career. We will pay for your fertility preservation. We will pay for your treatment. So ask your HR about that.
That's really helpful.
Yeah. And then going back to egg freezing. So before 2012, we weren't good at egg freezing because the way we froze eggs was completely different than the way we freeze eggs currently. Back in the day, I can't believe 2012 is back in the day because I felt like it was yesterday. But back in the day, 2012, we used to slow freeze eggs. So like an ice cube, you would slowly form crystals and then we would slowly thaw them out. And the egg, even though it's an egg, you can see it, it's the biggest cell of our body, but it's tiny, teeny tiny. So it would get ice crystal formation and it would crumble and break. So our thaw survival rate was very low. We did it as more of an insurance policy because the alternate was, well, just don't have babies, which is not a good answer, right? You don't want to hear that. But after 2012, we do what's called flash freezing, vitrification. And then we realized, oh, hey, if you flash freeze it, you don't get the ice crystals and our thaw survival rate is 80%. So your recovery rate is much higher. Most clinic, like here at Vios, we're closer to 90%, if not even higher than that. So you actually can get babies from these eggs. Okay. Embryos are even better because when you freeze embryos, you then join them with sperm and you know the ability of these eggs to then become a baby. And you can actually genetically test these embryos to make sure there's no Down syndrome, no trisomy, no other abnormality. So you can preserve a healthy set of embryos for your future kids if you want 3 kids, but not now, in X number of years. And then you don't have to worry about that biological clock.
That's awesome. A question and a comment to follow up. I'll start with the comment from Hannah. Resolve.org and fertilityiq.com have some great resources for employees and employers. Hannah said she made a case to her HRO for family building benefits today. Congrats, Hannah. I don't know how anyone could say no to you. And then Rachel Schultz asked a question. So what are your recommendations for seeing a professional about fertility? So I think she's asking, Rachel, go ahead, confirm here, about fertility testing, just to know if they actually are fertile before age 35.
100%. There's a shift in the conversation. Typically, the goal of doing all the social media, these panels, this education is to empower you. I would no longer like to see infertility patients, right? That's not the goal. The goal is to see fertility preservation, to come in and see me when you know, hey, I'm 28, I just matched in residency, or I just got my dream job, not looking to have kids till I'm 35 or X, preserve my fertility. So get your fertility tested. There's tests out there called Modern Fertility where they'll mail you a kit to your house and you do fertility testing. There's a bunch. I think there's called Everflow. There's another one out there. They mail you a little kit, you pinch, give them blood, they give you a whole report. Or if you're anywhere in the Midwest, the Chicagoland area, at Vios, we do what's called the Vios Pulse. It's $99 for full blood and ultrasound and a consult with one of our doctors to help you understand your fertility.
Oh, 2 follow-up questions, actually 3 follow-up questions. First is, can you take a fertility test if you are currently on a long-term birth control, like an IUD?
Yes. Remember, IUD is not hormonal, and if it's hormonal, the Mirena, it's just progesterone. So it should not, and it will not affect your ovarian reserve markers. You typically will most likely get a bleed or a light bleed. So you still ovulate and you still fluctuate. So yes, you can.
Second question as a follow-up. Is fertility testing covered by insurance in those 11 states as well?
Yes, it is. Most states actually cover diagnostics. They don't cover treatment. So all states should cover diagnostics.
Third question. This is for Jamie and Cynthia. Are you guys going to get into fertility testing?
Oh, good question. So, at Sticks, like I said before, it's all about providing women all the things that they need to comfortably manage their health. We love tests and we love diagnostics because they're a great way to be able to do that. We are, at least for now, really focused on over the counter because we believe it is the true front line of healthcare. It's where 93% of people like to start, and then they go see brilliant doctors like Dr. Jeelani and Dr. Yen and whoever else your primary care gynecologist might be. But we really are focusing a lot of our time, energy, and love on OTC, at least for now.
Excellent. Very good answer. Okay, I have two questions about menopause, but I am certain that there'll be more to come. First one is just general. What are the phases of menopause and what can we expect in them? And what can we do to be better prepared? I'm just opening that up to both of the doctors. Whoever would like to start first may go.
I can start with a brief. So as fertility doctors, we do menopause. It's reproductive endocrine. You initially start with perimenopause, where your cycles start to become very irregular, or not very irregular, but irregular, and you start getting some symptoms. And believe it or not all people experience the same symptoms. I think we hear about more symptoms than the people actually experiencing them. Menopause is considered one complete year of absolutely no periods, and then you have menopause. I know when we start getting irregular cycles and symptoms, we always go to our doctor and say, please test me, I think I'm menopausal, but there's actually no test to test for menopause. Can I draw your hormones? Sure. But are they going to tell me if you're going to hit menopause and XYZ? Probably not. Because everyone's body is very unique. So you want to address your current symptoms and what's bothering you. So the true treatment of menopause is address your concerns. It's more of a palliative, like addressing what's bothering you the most and make that transition easy for you. Dr. Yen, would you add?
Yeah, no, I think perimenopause means you're about to go into it, and it's I think of it kind of the car running out of gas, put, losing the kind of hormones, and it could be like a ton of blood, or it could be irregular blood, or because I've heard a ton of women who had perfectly normal periods and then all of a sudden they hit menopause and it's just getting weird on them and they're bleeding like stink or stuff like that. And so for people that are kind of perimenopause, pre 50 years old, I think you could consider going on the birth control pill just to turn off your periods, and then every 3 to 6 months come off and be like, am I done yet? Am I done yet? Rather than the randomness, that might happen. I also think we need to study, and anecdotally, that women that go into menopause on the birth control pill patch ring might have a smoother transition than the people who are just kind of letting the car run out of its gas, depending on how they go. I always think it's good to know your family history. So look to your mom, look to your aunts, and see how they went through it, and then see maybe how you'll get through it. But 50% of your genes comes from the other side. So you might need to look at your dad's sister, as well. And exactly as Dr. Jeelani said, there is no specific test that says you're in menopause, like most likely, and we can't predict when, and each person is different. And I also think the factors of like who's around you, like I have a 14-year-old and I haven't had any periods as long as I take my medicines, but I know when I hang out with 21-year-olds that cycle every 28 days, they have infected me with their period. And so I told my 14-year-old, I love you, but I don't want to spend enough time with you for you to infect me with your periods. We are not sleeping together in the same bedroom for longer than 8 hours, more than 3 or 5 days, because it has happened to me several times where I was in that situation for a startup accelerator or something, where these 21-year-olds got me with their periods.
I have a follow-up question too, because I know that there are some like surgeries and medicines and treatments for diseases and disorders that can also lead to earlier menopause. Do you know any of those offhand, and what should we sort of be aware of?
Well, I think any chemotherapy, obviously, and it should have been discussed with that person. So if you, and maybe if you're older now, and we weren't so aware back then, but now I'm in pediatrics, adolescent medicine, and we absolutely try to discuss fertility with anybody who are about to start chemotherapy for their leukemia or their Hodgkin's lymphoma or something like that. There is also something called premature ovarian insufficiency, and that is just random and oftentimes an autoimmune disorder. So if like thyroid runs in your family, that's an autoimmune disorder, or lupus or rheumatoid arthritis, then if any of that runs in your family, then this could run in your family. Dr. Jeelani?
Yeah, 100%. Premature ovarian insufficiency is huge. That's one of the most common things when people get off of birth control, and they start thinking that's why I don't have my period, because birth control put me in menopause. So I think that's huge. Chemotherapy, of course. Genetics is huge. Like I know my mom had premature menopause, so I'm at high risk for that. So just knowing your family history. Believe most people in their 40s are like, when you say don't get your period, they're like, hallelujah, I don't want my period, thank God. But you want to know that all these hormones are cardioprotective, they're bone protective. So you want to make sure that you're treating your body as a whole, that your reproductive organs, although we call them reproduction, right? They're not just essential for that. They're important for maintaining your overall health. So that's something that you do want to address with your doctor, that if I do go into premature menopause, how do I address that? What's best for me? And there's a lot of risks of hormone replacement therapy. So you want to make sure you're not a smoker, your BMI, all of that you discuss thoroughly before you get on HRT.
Some people are on it, I just wanted to put out there, for 10 years. I've seen one woman who's just on estrogen forever because when she's not on it, her brain doesn't function as well. And it's, about risk benefit ratio. So every woman's different. Every woman can, be on the medication for a long time or a short time. But I always thought, well, menopause technically is when it stopped for a year. So maybe that's but then after that is after menopause, or the continuation, the lack of the hormones, and how long you want to be treated on it. So it could be, 10 plus years on the other side. And then I just want to put out there to make sure people check for NAMS certified. It's the North American Menopause Society. So these are practitioners of many different backgrounds, could be internal medicine, family practice, OB-GYN, that have decided to specialize in menopause and stay up to date. So there are some people doing like testosterone pellets and other stuff that just aren't studied or proven. So the NAMS people are, evidence-based, safer kind of menopause treatment.
And then one follow-up based on all of that incredible insight, is there any way for this incredibly active group to sort of plan and prepare for a change in activity or a change in nutrition in that phase of our life?
Meaning, can you alter with nutrition?
More so like, how do we need to change our nutrition once we enter menopause?
I think, menopause puts you in an estrogen deficit. So if you're not planning on being in a hormone replacement therapy, and if you're trying to just kind of let your body transition naturally, you want to make sure you're getting the right amount of calcium. Want to make sure you're getting the right amount of vitamin D. They go hand in hand. Also cardioprotective stuff, so like omega-3 fish oils. There's certain vitamins that are catered towards perimenopausal, postmenopausal women that address all these concerns. So you want to look at all of that. If you are on hormone replacement therapy, then even though you've made that transition, it's adjusting for that estrogen part, but you still want to protect your bones and heart. Bones and heart are the most important thing that you want to address postmenopausally.
And I would say just throughout your life, it's important to be, as healthy as you possibly can be. So eating the plate model, where half of your every meal is fruits and vegetables, and a quarter of it maximum carbohydrate, and a quarter of it minimum protein. And in addition to that, as exactly as Dr. Jeelani said, calcium and vitamin D if you don't have the estrogen, but sometimes you need the estrogen to help with the calcium and vitamin D. And then everybody can benefit from omega-3 fish oils.
Love it. Love my plate. All right, we're going to do some rapid fire community questions because I want to make sure we get these answered. So I'm going to read these as if they were my question. I'm going to read them in the voice of the person who asked them. Not the voice, but the tense. First one is about birth control. I'm a little over 5 years of my Mirena IUD. I've noticed in the past year that I've had some spotting for a period, which is something I've never experienced before. Is that normal for an IUD, or is it just something else that has come along with turning 30? So I'm guessing that this person wasn't getting a period and they started spotting at year 5.
Yeah, so the Mirena IUD has been approved to go out to 7 years, but it was originally approved for 5 years. So I'm wondering, in this case, different people metabolize things differently. I would go in and get it swapped out and see if it goes away. But certainly metabolism can change when you're 30. Certainly if you added any new drugs, that can increase the metabolism of the hormones. I found personally Sudafed or ADHD meds rev up my liver and eat up my hormones faster. So I have to decide between breathing and bleeding when I have bad, evil allergies or a cold. And then again, if you have a new person in your household that has infected you with their bleeding. So I have a chiropractor and she's every 28 days. And she had a front desk person who was on the Mirena and never bled. But once she worked with that chiropractor, the chiropractor infected her with the every 28 days. And now the Mirena person is now bleeding. So just look around if you have a new coworker that you're spending 6 to 8 hours a day with, ask what their cycle is, and they may have infected you. But I would first just swap it out because it technically is every 5 years.
Oh boy, swap it out is the answer. Do you have something to add, Dr. Jeelani?
No, I was going to say swap it out.
Swap it out. The next question, also a community question. I think everyone is probably going to have something to add to this. So can you compare hormonal birth control to natural family planning? Also, what is natural family planning is my add-on to that, like basal body temp, cervical mucus checking, etc.
So exactly as you said, there's a wide range of natural family planning, and the more methods you add together, the better it's going to be. So if you can do cervical mucus and body basal temperature and use an app to anally track your things, then it's going to be a lot easier. But the problem is our body and brain affects things. And so all of us, I think, have had that point where you thought you were pregnant and then your period went even farther because you increased the cortisol level and your body's like, well, she wants to run away from a tiger right now. Now is not the time to pop out an egg and have a baby. And so it even pushed your ovulation even farther. But if you're using ovulation pee on a stick and basal body temperature and cervical mucus temperature and all that, all 4 of those is going to be better than if you use one or the other. I would say the ovulation method is absolutely good because it's telling you your egg popped out now. And so, you have a 5-day window on either side, but it would have been nice to start 5 days before you ovulated to start having sex if you wanted to do that. And so according to the contraceptive technology, if you're using the ovulation method, 23% will get pregnant, meaning if you're trying to prevent pregnancy, it's not so good. If you're using the 2-day method, I have no idea what that is, 14% will get pregnant. Standard days, 12% will get pregnant. Natural cycles is 8%. And then the symptothermal method is 2%. But I'd say you have to just really have to have regular periods. You have to be able to check your temperature before you get up. And generally all the family, fertility awareness methods are worse than any pill, patch, ring, IUD, implant, or shot.
Anything to add?
I was going to say they don't work. It's basically what Dr. Yen said. In short summary, if you don't want a baby, don't do it. Don't try a natural method. The egg releases 24 to 48 hours. Sperm has the ability to stay in your body for up to 5 days, plus or minus 5 days. Yeah. Plus or minus 5 days from ovulation. So even if you didn't have sex and like you had sex 5 days before and then you ovulated, and that sperm is still lingering around, guess what? It's a little too late. So if you don't want a baby and you know that, just use birth control or condoms.
Cynthia, Jamie, anything to add?
We see a lot of customers that actually test their ovulation in addition to being on hormonal birth control, just as kind of like that second layer of defense, which is an interesting concept and something that I think a lot of women are interested in, but maybe feel guilty or like embarrassed for wanting to do. But there's nothing wrong with being extra careful if it gives you peace of mind.
And actually, just so you all know a little background on the birth control pill, it was originally formulated at 110 micrograms of estrogen. And now it's at 35, 30, or for older people, 20, or for crazy people, 10 micrograms. And so that's 1/10 of its original strength. And the research has actually shown that if you're off the birth control pills on day 5, 6, or 7, you can actually have escape ovulation, particularly if your body mass index is higher. So I suggest everybody that's trying to prevent unplanned pregnancy, go right now to a BMI calculator, punch in your height, your weight, check your BMI. If your body mass index is 26 or greater, know that emergency contraception plan B specifically in its generics is as good as water. So do not use plan B for emergency contraception if your BMI is 26, but instead you can get Ella, which works up to a BMI of 35. But if your BMI is 30 or 35 or greater, many birth control methods will fail you. And part of it is that escape ovulation. So yet another reason to shorten the days off your pill patch ring to 4 days maximum if you're on the heavier side, or if you're worried about escape ovulation, or in my case, I say just skip that bleeding altogether. Except for if you're on the patch. You can only do that for 12 weeks in a row. Otherwise, the estrogen builds up and there's a risk of blood clot. So you can do it every 12 weeks, have a bleed, but don't go longer than 12 weeks on a patch.
Wow. Couple questions about hormones imbalances and testing. So you mentioned PCO, we have PCOS in the question here, but there are a couple different letters used for that. So what are the early signs of PCOS? How can women avoid finding out about cysts only when they start trying for conception?
Cyst, it's a misnomer. It's not it's called polycystic ovarian syndrome because we were not good at sonography. So when it first was diagnosed in the 1970s, they saw a bunch of what it looked like now follicles on the ovaries. So it's not really polycystic. It should be named polyfollicular ovarian syndrome. It means that you have a bunch of eggs on your ovaries. We don't know what activates the eggs, but we know that they're activated and they sit there. So how do you find out that you have it? It's actually a diagnosis of exclusion. So you rule out everything else and then you say, that's what you have. You need to have 2 out of the 3 criteria for the criteria that we use here in the US for diagnosis. So number 1 is polyfollicular ovaries or enlarged ovaries. So meaning greater than 12 follicles on either side. Okay. Number 2 is biochemical or clinical signs of hyperandrogenism, meaning you feel like you're hairy. And you don't have to look like a gorilla. I have PCOS. I hope I don't look like a gorilla, but it's male pattern hairiness. So you want to look at, there's a scale that you use, it's called the Ferriman-Galloway score. And we give them a scale and you measure like hair on your knuckles, upper lip, chin, how wide is your pubic hairline, how high does it go? So is it male pattern driven? Is it testosterone driven hair growth? And then acne, and it could be biochemical, clinical. So you could say, wow, I don't feel hairy, but I may check your testosterone and it may be high. But I also want to rule out other forms of testosterone secretion like tumors or adrenal issues. And then number 3 is irregular cycles. So cycles greater than 35 days apart. And I recently saw a patient, I said, oh, do you have a regular period? And she's like, yeah. And then I got to my end. I'm like, okay, we'll call with your next period. And then she was like, okay, well, that's not going to be for like another month and a half. I'm like, what do you mean? And she goes, well, I get a period like every 35 to 40 days. And I was like, well, that's not really regular. So let me tell you what a regular period is. So making sure that you get a cycle between 21 to 35 days. Greater than 35 days is not normal. And also shorter than 21 days is not normal.
Super helpful. Okay, I'm going to rapid fire some questions.
I just wanted to throw out, if you Google PCOS and Pandia Health, there's an entire blog on it. And there's a talk that I gave for Stanford on how you can start approaching it with diet and nutrition, but then consider birth control pill, patch, ring, and or metformin, because it depends. If you're an endocrinologist, the answer is metformin. If you're an OB-GYN, the answer is pill, patch, ring. If you're a primary care physician whose job is to take all the specialist information and give you the best option, I would say both. So if you were my daughter, my patient, my friend, I would say birth control pill to deal with the hairiness and man hormones, and the metformin to deal with the metabolic side effects of polycystic ovarian syndrome.
Very helpful. And there were quite a few questions about that, actually. So thank you for spending some time on that, because I know we all wanted to know. 2 rapid fire. 1, does the Nexplanon birth control implant lose effectiveness at a certain BMI?
Good question. Yeah, Nexplanon. I think that's one of the ones that it does.
It does. I think a BMI over, my God, I don't do OB-GYN anymore.
It's probably 35. Everything.
Yeah,
cuts
like
off
I
at
remember from
35.
my training. Same thing, metabolism, hormones.
But
goes
the
in the-
IUD doesn't, because it's local and focal.
Correct. So anything that does is hormonally related. It has to go through first pass and metabolism. So that's when your metabolism and your weight take into effect. IUD is more mechanical and localized. So it's completely different concept. But yes, Nexplanon after a certain BMI does.
Excellent. And last question, then we'll get out of here. It's 7 p.m. in the central time zone. We've got some people out west, some people out east. Kia actually asked if anyone's never been on birth control ever. She actually said anyone else. So if you haven't, go ahead, throw that in the chat. I think we have a few people. Winnie also shared in a question, I just turned 31 and I don't have a partner. I want to have kids, preferably naturally. And I hope to do that within 2 years or so. Would you recommend she go the natural route or freeze her eggs? I think we know the answer, Winnie.
I'm going to cite a study. So women, your question is basically, I want to have kids naturally. If I find the right one and get pregnant and try in 2 years, do I need to worry? It depends what your family size looks like. So if you want 3 kids, then yeah, you may not need it for baby number 1, probably baby number 2 or 3. But women who likely use their eggs are the ones who freeze their eggs in their mid-30s, because that means that in the next 2 to 3 years, they don't envision having a partner or being in a position where they're ready to have kids. By the time they get there, they're going to be in their mid to late 30s. And by the time then they start trying, then it's going to be harder and harder to have baby number 1 and even possibly build their family. So those are the ones that actually go back and use their eggs. So if you're, I know she said no partner. So I would say yes, freeze your eggs. And sometimes it was hard for me. It was really hard for me to say, well, I'm not going to do fertility treatment. My husband's like, but you're a fertility doctor. What do you mean? I was like, it's not for me, but sometimes it's hard because that's not how we envisioned building your family. But at the end of the day, it's okay because the end goal is family. And I think it's important to remember that.
So just a quick follow-up on the Nexplanon. There was a research study in 2012 by the Contraceptive Choice Project, and there was no difference by BMI for Nexplanon. So the Nexplanon, the IUD with hormone, and the copper IUD are all fine, regardless of your weight.
Thank you for adding that. I know that was important. Okay, so we hosted this panel on International Women's Day. We hoped with all of our hearts to empower all of you who are attending and all of you who are watching after with information so that you maybe don't feel so alone with your questions. So as we bid you adieu, I'd like to give everyone an opportunity to give some parting thoughts. I did not prepare you for this. So I'm going to start with Dr. Jeelani, because you're off mute.
Thank you all for having me. It was very nice sharing my own experience and educating and empowering. This is exactly what I started my social media for. So if you ever have any follow-up questions, I do a lot of Q&A. Gina, are you okay if I share my social media panel?
Go crazy.
Okay. So you can find me on Instagram. It's Roohi Jeelani MD, or on TikTok, but I do a lot of Q&As because there's so many questions like this, and don't feel ashamed or embarrassed because this is truly something that we never hear about or learn about, right? We always learn how not to have a baby. So all of a sudden when we have these panic moments, it's good to ask, and you're not alone. Look at this, like, look at how many women are sitting here on Monday, like one, empowering and educating you, but also trying to learn themselves. So thank you for having me.
Thank you for being here. I'm going to go to Jamie next. Jamie, any parting thoughts?
Yeah, thank you guys for being here and for taking the time to ask the questions. Similar to what Dr. Jeelani just said, we get so many questions and everyone thinks that they're alone in asking them, but there's this huge community of people who want to learn about their health and make more confident decisions. We post a lot of articles and Instagram lives and Q&As and all that good stuff. So I'll put our stuff in the chat. Yeah, thanks for having us.
Thanks for being here. And we'll make sure to send everyone's socials and links out afterwards too. So you'll get access to all of this, friends. Cynthia, you're up. Parting thoughts.
Yeah. All right. That was going to be my really wise parting thought. So now I have to think of another one. Oh, yeah, I have a good one, which is that I think it's so important, especially as women, that we all take control over our own health. It's so confusing and there's so much that we don't know. And so I think coming here is an amazing step in doing that. I think continue on this journey because it's incredibly important.
Awesome. And Dr. Yen.
I want to, just put it out there. Please educate all of those with uteri that you can make hashtag periods optional. If you Google Pandia Health periods optional, you'll see my TEDx talk on the bottom on the science of safety of having fewer periods and how it decreases ovarian, endometrial, colorectal cancer, anemia, and landfill, and increases women's productivity. And I think it's amazing, and I'm thankful that aSweatLife has put this panel together, allowing all of us to come together and ask questions and learn from each other. And we also have a great article on Pandia Health's blog on good versus bad telemedicine. So check that out if you're looking at any kind of telemedicine providers. And we do a Facebook Live that streams to YouTube every Tuesday Pacific time, 5 p.m. in Espanol and 5:30 in English. And we partner with any female-founded, female-led company that's doing amazing stuff to do Facebook Live. So maybe in the future, we'll be doing something with sticks.
Yes, that would be so great. Sticks and Pandia. Okay, friends, this has been excellent. I am certain that there'll be more questions for you. So we'll make sure that your Instagrams, your links, everything is all in the email afterwards so that every attendee has access to you and your businesses as well. And with that, I thank you all from aSweatLife and from all of the attendees for being here. Good night.